So, are we live, Gaurav? Okay, so we welcome everybody again, yet to this another series of our Surginar. And the idea of Surginar, like always, is that you will be able to see the live surgery from the comfort of your own laptops and your own desktops, in your own residences or in your own workplaces. And today in this series, we have a very accomplished surgeon who needs no introduction, and Dr. Jethwa from Jethwa Eye Hospital is going to be demonstrating 4 live surgeries in front of you. And I would now request Dr. Jethwa to start the live surgery program. I would be joined in very shortly. I think Dr. Rajesh Sinha is going to be joining in very shortly to moderate the session. And over to you, Dr. Jethwa.
Yes, good afternoon to all. Thank you, madam. Thanks to Dr. Rajesh giving me this opportunity to demonstrate surgery, and I'm glad that you also, have given chance to a surgeon from a small town, and it's really a pleasure. So I am from Anand, and Anand is a small city or small town in a Gujarat, and that is it's a mill city of India. It produces 24.3 million liters of milk per day. So today we are going to demonstrate 3 cases full, and last case a little bit if time permits. So just over to slides, please. Deepak, can you start? So this is the first patient. Can you make it full size? I can't. Yes. So he's a 62-year-old male,
Yeah, we can see.
and we have planned for topical IOL under topical anesthesia, and we are going to use Technics Toric 2, which is a latest generation of toric IOL of the Johnson & Johnson. I have no financial interest. Second thing is our vision is a pure cortical 6/9 6/6 partial with pinhole. It's a cortical cataract, fundus is normal, and diabetes, blood pressures are controlled. There is no any other positive finding, and blood reports are normal. Next. This is a ILMaster 700 chart. We would like to do each and every patient with a total keratometry, and we calculate almost all the patients with the Barrett formulas. Next. This is a Barrett toric calculator. You can see here that we have mentioned the incision at 180°, and there are 2 types of incision which I have written with the blue pen. There is 2.4, which gives a SIA of 0.2 diopter, and 2.8 incision which gives a 0.3 SIA. So you can put the incision at a different level, and you can increase or decrease the size, making sure you can see at the bottom that is ZCT 300, which gives a residual cylinder of 0.01 cylinder only. So you have to make a adjustment in such a way that our target should be as less as so far as the cylindrical part is concerned. This is a normal oscillity and topo. There is nothing to say about it. And this is our final workout sheet or printout. We make it to all. You can show here. You can show this, which is hang over a microscope. So I'm turn karta. Yes, that's right. So you can see this. So this is a last moment printout we keep for each and every patient, which shows the different thing, which type of the IOL, what is the residual power, what is the endothelial count, what is the SED, and it is software connected, and there are multiple formulas and algorithms are there by which the software will say whether you use a trypan blue, whether you are going to use a mannitol or something for when the SED is less, whether you are going to use more viscose if the endothelial count is less, what is the position of the surgeon. Yes. So in this case, we are going to make a temporal. You can focus. So we made a special design of a. You can see the left eye and the right eye. We made a circle like this, which is very helpful for putting the position of a surgeon. So my right hand will be at a 180 degree here, and we are going to start the surgery with the temporal approach. Give me the spectrum.
That's
So
a unique and a wonderful thing.
I think we've not seen this before, and this is truly a treat to watch. And I think it is something which everyone should also adopt. So really nice, Dr. Jethwa, very nice.
Thank you, madam. Thank you. So
Your entire workup is just absolutely meticulous. I mean, right from the beginning.
So our workout will, guide you what to do and which precautions to be taken. So now, cornea पर wash ना बहुत ज़्यादा प्रेस नहीं करें या फिर इधर में चला जाएगा. I think now you can see. Can you trim it? So the center part of the microscope. Can you trim it?
I'm really sorry for joining a little late, but what I can figure out, is it a toric implant that we are doing now?
Yes. So there are, can you show this again? There are two markings here. You can show this. Here, this. So you can see there's a 2 degree and 0 degree. So this marking is done as per my own toric marker axis marker F, and here the temporal side it is 2 degree and nasal side it is 0. So from that we will put the desired axis. Yes, over to microscope. So when you go for the next patient, I will have a 6-minute video how this app is working.
I think it is again a a great innovation and a great way of doing it.
So I put 2 incisions at a time. Okay.
You make both the incisions simultaneously?
I don't touch conjunctiva.
Okay.
It is not my. I've seen somewhere of the ones Israel surgeon was operating.
Okay.
And I got the idea from him. I forgot the name of that surgeon.
Yeah, but that's a very good thing. Because if you touch the conjunctiva, any hemorrhage is there, the whole advantage of doing topical phacoemulsification is gone, because the patient keeps complaining of redness.
Hydro. Everybody got hydro. Is the microscope focused?
Yes, very well.
Just try to remove the air bubble. Light full. एकदम फुल ना जाता.
एकदम फुल रख दो. XY चालू.
ठीक है. A little bit nervous actually.
So you put Helon in the anterior chamber, or is it Visilon?
Yes. First, I forgot to tell. The first was a Helon.
Okay, and then now you are doing the Rexis from the side port.
I'm sorry, I'm a little bit nervous.
No, not at all. Not at all. I think.
Focus. So I followed the margin of a, pupillary margin to make the round pupil. And if needed,
2.4.
no,
Visilon.
it's again a new way and a very good way of keeping the maintaining a round rhexis, that you are following the margin of the pupil.
Yes.
2.4.
The second thing, I put the main incision now, because otherwise what will happen during the doing the rhexis, interchamber will
2.4.
Yeah, it will become shallow, and I think that is why it was a perfect circle, because your main incision was not there and this was being done from the side port.
this is a 2 degree and I am putting an incision at 180 and this is 2.4 kiloton. This everyone knows the simple hydro, and I use the signature phaco machine of Johnson and Johnson, and I use the dual pump. For few steps I use peristaltic, for few steps I use Venturi. So now it is almost hydrodissected. Yes. So best is to rotate with the two instruments, because there is no push and pull effect. A little bit you can reverse also.
Yeah.
The reverser helps in separation of a epinucleus.
Very nice.
Phaco 1, you can, expression range is 40, vacuum is 150 and power is 40, and it is a white star cold phaco. Why I have kept peristaltic in phaco 1? The reason is to cool the tip and make the tip cool all the time, because it requires maximum amount of phaco emulsification. You can see, observe the tip of phaco tip. You can see now it is seen. So
Yes.
direction of tip is changing when you are going a different part of the nucleus.
So you normally would make a trench in all the cases, or you are making it here because it is a grade 2 to 3 cataract?
Sometimes I chop the whole nucleus with two choppers if I see the golden ring.
Okay.
So I am going for a phaco 2, trying to separate the nucleus.
350 vacuum, 45 power.
Just let me know if the microscope is not focused.
No, it is perfectly all right. We can see its centration is also extremely good.
Thank you, madam. So I am trying to separate the central part of nucleus also. So now it is separated. Hold the one part. Very simple stop and chop.
350 vacuum, 45 power.
You can take it, or if it is entangled, you can go for the second half to make the pieces, depending upon your conveniency and depth of entry chamber.
So what is the power of the intraocular lens that we are going to implant?
It is 21.5
Okay.
ZCT 300.
300 vacuum, 35 power.
You can see, as the cataract is not very hard, my Otis sister has reduced the vacuum
Yes.
from 350 to 300. Now you can see that now only 2 or 3 are there,
275.
fragments. So she has reduced further,
Yeah.
275. So
I
it is
think
still
that,
last, a very small is there. So
yes.
you can go for a 250 only.
It does make sense to keep decreasing it because your contents in your bag are decreased, and so there is more mobility, more space. So as you decrease,
200 vacuum.
it's
Second thing, we
really,
are operating in a 2.4 millimeter of incision.
yeah,
Want to be little bit restriction in inflow and more chances of
Necklace.
surge. Smaller the incision, more chances.
yeah.
So now it is epinucleus. Just hold it, catch it, then pull it, and after pulling, you absorb it like this.
Excellent, excellent.
So this is how you can pull in different direction so that the epinucleus is separated out. This step depends upon the depth of the AC. If AC is deep, you can do it. Otherwise, you can leave for cortex. I think I'll leave for a cortex removal. Irrigation is on, and as I learned from Dr. Vasavada that you must inject the Vizuron. थोड़ा छोटा है, small है, small.
Syringe देना.
वही देता ना, चलेगा चलो. Because it is a 5 cc syringe, I cannot. That I'm habituated with.
Continue on.
So you can see now I inject it,
Yes.
and then I remove the. It is not necessary all the time, but when the speculum is very tight, chamber is very shallow, patient has a posterior cataract, you are feeling that it was a hypermature white cataract and capsule is very thin, we can go for this thing.
I think it's a good thing to inculcate in your own habit that, once you're taking out the probe, it's better to inject viscoelastic from side port. So that will become a habit.
Yes.
It's a nice.
Second thing is between all the steps, my habit is to inject viscoelastic. So when I change from one step to another step, it is not without viscoelastic. So I remove the air bubble first, like this, and then we introduce it. So otherwise, bubble creates trouble. So as
Use by manual.
Bombing is a fantastic thing,
Yeah.
which is invented in 1991, and Dr. Peter Lindberger of Switzerland, he is from Geneva University. He taught me that you forget all, you follow this. So from 91 we are using this. My first implant was in 1983 September. So we have a okay. You can see now there are some tags are there, which is beautifully controlled very well by good machine. You can remove it, all the tags, and make it polish. Vizuron. So Vizuron is on. Maybe
Continue off.
the micro movement of the posterior capsule up and down can transmit the waves to the macula, and that can also create a CME, postoperative, which was explained by Dr. Darjit Singh.
Yes, I think tremulous, any repeated tremulousness in the anterior chamber can create disturbances at the
Exactly, yes.
level
Yes,
of the vitreous also.
So over to the lens we are going to implant. This is a 3-cylinder 21 point diopter. I think you can see, and it is a, the difference between techniques 1 and techniques 2 is you can see the golden and rainbow shining of a material. I think you can appreciate it now. There are golden and rainbow. This is the polishing of a beautiful polishing of this lens. So just like folding our arms, we can fold the lens, push it gently as much as you can. And I put a viscoelastic and also a drop of moxifloxacillin over the viscoelastic. So now this is ready for implant. Even we can put it in a 2.2 incision also.
So you use a screw system or a push system, sir?
Push system should be discarded all over the world. I had very bad experience. It is not a good system. You cannot control. Here you can control in both the ways, forward and backward.
Yeah.
And I love the screw system. You can see now it's partly gone in a bag.
Yes.
And next you don't touch, don't do anything. Just put a viscoelastic and put this folded loop inside the bag. Sometimes, you know, the loops love each other so much that they don't separate.
Yeah. I think this happens with some of the lenses.
Yeah. So, but you know, my sister always takes care. She first put the Iziron over the oil both the surface, and then we fold it. So once the loops are coated with viscoelastic, then the chances are less. They stay stuck. If it's too much, then what I'll do is I'll not continue like this. I'll again inject, as I told you, again inject the Visalon, and then I do some maneuvering to separate the loop. It is better not to. Yes. So this is a safer way to use viscoelastic.
But there is a question which is being asked, and that is that are you following the precautions which you were following in the pre-pandemic era, or have we all shifted to a near normal level? So I think gradually all of us have shifted to the near normal levels. How about you, Dr. Jethwa? Do you follow some extra precautions for the possibility of COVID being there, or are we?
We go for two things: ask the history of common cold, any fever, and CRP.
Okay.
And any family who is suffering in, you know, suffering in family COVID is there or not. Okay. Now you see, now we know that this marking is 2 degree, and I'm going to put it at 2 degree exactly. Axis So we are making it 0. So more or less 1 degree only difference is there. So from 2 degree we have marked 0 degree.
Okay.
I draw. You saw that there was some leakage from the main mold. So I do the partial hydro. And final hydro I will do later on. Why? The reason is, if I do complete hydro and by chance the cornea is also hydrated, then I can't see the axis. So it's a
Temperature sir, temperature 0 degree.
हाँ ये तो
175
हाँ मैं तो जीरो मार्क कर दिया है.
175 IOLs.
So by irrigation I remove most of the without much aspiration most of the visco, and as we all know that it's very important to wash the viscoelastic on the back side also, which I am trying to remove it. We will put the marking with nullifying all the Purkinje's images more or less 0 degree. Wash time करने पर bubble से. You can see now
Yes.
it is at more or less 0 degree. This lens can move on either side. If it does not move, make the lens vertical and then rotate. It is easy to rotate, you know, like a coin.
Yeah.
Still, I am trying to make it at 0. Yes, now it is 0. Perfect. Hydro. You do the hydro.
Hmm.
I should thank the patient also who cooperated very well. By hydro, I take 2 hands, not a single-handed. Hydro should be done with the 2 hands. Now the last and very important step for toric lens comes, and we observe that sometimes it gets rotated, and it's very common in this design of a lens. Light માં જુઓ તો low height કરો. And keeping the height little bit low, 65, 70. I see I'm just pressing the optic and touching the optic, little bit press over the capsule. So there is any fluid behind the IOL can be corrected. Rotation no. Still rotation is not as good as I want actually. It is, you can appreciate that it is not in a right position. Yes. Now you can see it's more or less okay. So you can take the support of specular or anything and inject moxie in the Germany, a little bit over the surface of cornea, and that's all.
Okay.
Nice.
Okay,
Thank you. Thank you so much. That was an excellent demonstration, Dr. Jethwa, of every single step. And I just wanted to ask you are injecting intracameral moxifloxacin in all your cases?
Yeah, 100%, 100%. Because there was a study before, I think 20 years, by American Academy of Ophthalmology, that they have taken a culture of all the patients after finishing the surgery. They took away a little bit fluid from the AC and cultured, and they found that 43% were positive. It's the immunity of a patient which does not allow the infection. Bacteria are always there, but if you are giving a prophylactic moxie, it is very helpful for preventing the endo and any infections. So
Yeah, that's true, sir. Actually, that's why perhaps these days, world over, people are preferring to put intracameral antibiotics at the end of the procedure.
So before the next session comes, can I show you a 6-minute video because
Sure.
that's about the how we have marked the toric this thing. Can you start?
Okay.
Yeah, I'll start. Start. No, not coming. Yes. Can you make it full screen?
Can we have the audio if it is there?
Yes,
Audio
no.
cannot be-
Audio is there.
No, we can't hear the audio. I think they have to increase the volume of the audio.
Ah, bye. Sarah, thank you. Fine. Thank you. Thank you. Can you see that? I think start here. Let's start. It's a it's a simple
I
way
can't-
of.
Yeah.
I think I have to narrate it. Right? Audio is not coming somehow. There is some
Okay.
technical problem.
Okay.
આવે છે? Coming? No, no,
No, it is not coming.
not coming. Okay.
Yeah.
Okay. Okay. So this is just start. Yeah, yeah. Are coming? No, नहीं चालू. चालू. Yes. So this is I am explaining how we have developed the toric marker. Of course, there are good gadgets are available like Varion and other things. So so this is how we are taking a photograph of a patient's eye with a and the camera is zeroed by the spirit level, and this is a Wi-Fi card, which is Wi-Fi SD card, which is inserted in the camera, and which gives a wireless transmission of image from the camera to our Android application. So it is Android applications which is available free, and there are multiple ways. Either you can take a camera, or you can take patient's image directly, and the app itself will find mention that what is the degree of a picture you are taking. Once the picture is taken, you can see the picture is taken, it is clicked, then it is transmitted to the our app. In app you can mark any place. You can mark any place, and once it is marked, you can there is a Wi-Fi SD application in which you can transfer the image to application. Once it is transferred, it is, you can see the images are transferred. So now it is in your gallery, camera's gallery, and once it is downloaded, you can open our app, which is available free on Android platform,
Okay.
Google Play. Second way is you can take by direct mobile also, whatever is convenient to you. Can you make it little faster to save the time? Yes. So this is a app. You can take directly a photo also. Can you make it faster? So in this case, we have opened the toric marker, and we import the image to the app. And once the image is imported from the gallery album, this is the image, and you can see a yellow circle which is by the touch, it can be expanded or it can be, there's something wrong.
No, we can see the yellow circle.
Okay. So it can increase or decrease. Can you see?
Okay. Yes,
Yeah.
yes, we can.
Yeah.
We can.
And it should be aligned with the limbus. Once it is aligned, you can go to the step 2, that is the axis, which shows the axis. I'm just making a fine centering, and once it is centered, you can go to the step 2. I think there is some Wi-Fi, video Wi-Fi. Some problem is there. It is using Wi-Fi. Yes. Little forward now. Little forward. Yes. Little come. Wi-Fi pollution actually. That's a problem. You can see now the multiple axis has come.
Yes.
From this axis, you can touch the any axis and you can move the, you can align the axis to a where you mark the initially. So you can see, you can move it any place.
Yes.
And this should be transferred to the, you can print it, you can transfer to your OT, and this is a final picture. So you can mark any place in a cornea, and that particular axis will be shown by the app, and we can follow the further step as I explained earlier. Thank you. So we are proceeding for the next case. Can you show the next case?
So this app is freely available on the app.
Yes.
App store. Yeah.
Only thing, you need a very good camera, which is aligned exactly at 180 degree. Take the shining spot of the patient in a left eye, then same in a right eye, and see that the patient's head is not tilted here and that way. And once it is head is in a aligned position, camera is in aligned position, take the photograph, import in your app, and in app it will show all the axes, particularly the axis you have marked with the blue pen or with the marker. So this is how once we get the exact axis of any place, we can following that we can get another axis also.
Okay.
Thank you. So we are proceeding for the next case, and that is the a female 58-year-old. We are planning for phaco with an implantation and topical. Here again it is a toric 2 and it's a cortical normal fundus. Diabetes under control. And here there is a positive finding. You see, the positive finding is endothelial count is less than 2000. Now you see, next. Now this should be taken care. This is the scan. Next. You see, here I am not saying this. Here you can see again here that I have not put the incision at 180 degree or 0 degree as regularly we are doing. To make the cylinder 0, that is you can see the ZCT225 is 0.02. To make it, what I have done is I put the incision at 135. See, as I told you earlier, we have to play with the placement of the incision, the size of the incision, and at the end, the cylinder should be less than 0.25 or so. So here the desired is only very less 0.02. So this manipulation you can do it next. So this is all normal. So this is the same picture which I was telling of the same patient we have taken. So you can see that on a left upper corner there is a blue line, ocean blue line. So there is a place of incision, and you can see the other side there is a axis which is marked. Next. So we can now mark 90 degree on both. Here you can notice that the, can you magnify this? Right click करें, magnify करो, zoom करो. You make the A करो. How do you करो? Yes. You can see now in a right eye, 1934 is endothelial count.
Yes.
So here I have developed a software that whatever precautions we have to take, all the data are entered by the optometrist, and automatically there is a highlight of injection Oracor or injection Viscor we have to use more in this particular case. So this is how we can prevent the complications and make the outcome very too much better. And on the right center side you can see the size of incision is 2.4. Can you make this right side? Here there are two lines. the red and the green. The red shows the steeper. It is automatically done by the software. The red is a steeper and green is a flatter. So usually I put the incision. If it is not toric, I always go for the steeper incision, and I can put the incision any axis. There is no bar about it. So I can put, and we can neutralize the pre-existing astigmatism in all the cases. Okay, thank you. So I'll just just prepare the patient and we go for the next case. Thank you. No, fine.
So I see that there is a rod which is there and your drape is over the rod. So I think this is for the patient comfort, that the drape is put over the rod so that the patient is able to breathe. As the patient is lying down, we can see.
Sí, gracias. Yeah. I understand. No, coach. Yeah, I asked him. You can focus here. You can focus this. This oxygen. Oxygen. Can you see the oxygen pipe which is coming?
Yes, sir. Yes, sir.
So they same is coming. You can see up to this. You can focus here.
Yes, sir. Okay, this is going there.
Patient is getting the oxygen below the drape.
Okay, okay. Got
So
it.
that's the reason of a slit, a still. And now here you can see, focus here. It is 135 degree here. So my right hand will be here. So I'm going to put the incision exactly at 135, more or less. And second thing is, if the patient is not comfortable in a vertical incision or in an oblique, you can say the axis, then you can, sometimes I make the head little bit down. Can I make it down? Yes. So more eye is exposed. Now you can see I am comfortable, patient is also comfortable. Kamu બેન છે ને? Kamu બેન alright છો ને? ચિંતા ના કરતા, સરસ થઈ જશે. Don't worry. Okay, બંધ કરો. So you can see the roughly incision will be 135 here. You can make an exact marking if you want, but to save the time, I'm not going for that marking. And light માં જુઓ તો light off કરો. So this you can do here SE also. It's not a much problem. First thing I'm going to inject is Xylocard or Xylocaine preservative free. After that, the Viscoat or Orocoat, and in this case, I have used Hilon, and below Hilon, I'm injecting the methacellulose hydro. The reason is that I'm more comfortable in Rexis when viscose is over the capsule. Okay, I think this is enough. Hilon. Air came on, listen. Okay, so finish. Wash now. Nothing like that. Say so. So again, you can fix the eye with the left hand very gently with a very soft forceps.
Yes, I think we can see that very well.
Make 4 punctures, 1, 2, 3, 4, for a very junior running phase of a axis, and join all the 4 puncture, and then push it and create a flap. Light much right? If the pupil is regular, try to follow the Elon is softer than viscose. Okay, it's okay. Yes. So here it is 2.4 incision I am putting. At 135. Okay. इसको लिख देना नेक्स्ट केस में ये लिख देना इसमें लिख एक्सिस so this is a hydro. If you like my like if you feel like you can do hydro dissection also and hydro delineation. And as I told that between all the steps, I inject viscoelastic. You can rotate it. Sometimes I crack like this. So we can directly jump to the FECO 2. I think, have you observed this? Hello? There is no connection. There is no connection. No, no one is responding. No one is there. Hello? Can you hear me? It's okay. But it is going alive. Okay, that's good. No problem. So you are seeing that I have cracked the nucleus by a specially designed chopper, and I just directly jump to the record 2. This is a confirmative step that the 2 pieces I made are completely separated out. Dr. Rajesh, are you there? નથી આવતું તમારા લિંકમાં જો હતો you open the link and see. So reducing the vacuum. Visual novel. So using more and more Helon because the endothelin count is less. So you saw that I cracked the online zone. Can you hear the sound? Checked? Okay, good. Those panelists are not there. Okay, so you can see that I have reduced the FECO power by making the 2 halves of nucleus by specially designed chopper. Use very low vacuum for engaging the epinucleus. Now, center.
Standing.
So as I told you that we inject the visco before removing the phago probe. If you like, you can supplement and make the chamber deep. Posterior capsule track. Yeah. Is it live? Can you call to sir? Okay. They are not there. Call to Dr. Namrata. So very simple step, as you know, the catch, pull and aspirate. Catch, pull and aspirate. This is the way. And then we go for the fine polishing of posterior capsule. I think you can appreciate now. I like to inject in Visalon, under Visalon. Stop. Irrigation is stopped now. I'm injecting the visco. Keep the chamber filled all the time. More or less all the steps of IOL. Okay. So again you can see this is ZCT 225 25 diopter, and this time I will put a little bit, a drop of viscoelastic over the lens so that it does not stuck. So chances of entanglement of, you can say, the stocking of loops are less. Okay. Go to Sami. Okay. Sit. Yes. It is 2.4 incision, technohistoric 25.5 data with thicker lens, and cylinder is 225. Before this gets opened up, inject some Visalon, taking care that you don't touch the endothelium, and push it in the bag. Yeah. First I think I remove the, I make the marking after once I am confirmed that yes, now it is open. Is that? So why? Huh? Okay, okay. Visible. So Delhi ma nothing, eh? Okay, good. So here the again the temper bone, as our application says, is this is a left eye sir. No, left eye sir.
Right eye, sir. Only 80 degree.
Right eye sir. 2 hours. Yes. So this is 2 degree, and I'll position क्या है?
Only 180.
So I'm keeping this at 2. So hardly there is some marking needed, because so this is 1, this is 178 means 2 only. So not much marking required, because the original marking is more or less same as what we want. So just press the posterior lip, give a only irrigation, because the binding of hilon and endothelium is so strong, you should not aspirate, you should not use the suction. Otherwise, it can take away the endothelium also. So making this removal of this visco behind the oil. And keeping this axis, again all the three Purkinje's images should be neutralized, make it one line, and you can see it's exactly at 180. Like much over? वो सरस है ना? So making this hydro completely. Okay, good. Now what I do is I release the speculum and lift it little bit up, and what I do? To show it, I'm trying to remove the bubbles in an anterior chamber. Now, there are very common thing and question there, why it rotates, because there is a fluid behind the, so I'm pressing little bit, you can see, pressing little bit, so that the fluid behind the IOL is more or less milked out. And this will be done with the keeping the speculum loose and up. And this is how I inject the viscoelastic. Sorry, moxie with BSS.
Right.
So this is over now. We'll go for the next case. Is there anyone is there? बेमारी कोई नहीं है? अच्छा तो okay.
Connectivity issue, so there was a little
No
problem.
problem.
Yes, can we move to the case?
So we have just finished the case just now.
Yes.
This time I showed a little bit something different, that
Okay.
it was a case of a low endothelial count. So
Yes.
what more care you have to take. Second thing, I not use the FECO one part with the
Okay.
help of a chopper. Once you see the golden line, then you can have a assessment where the edge of the decrease is there. Just with the two choppers, you just crack it and make it two pieces. So this much FECO power is reduced, and we can save some endothelium. And second thing is, as I told you, after finishing the surgery,
Yeah.
remove the speculum, lift it little bit up, and push the fluid, and again milk out the fluid whatever is there behind the toric IOL, so that the posterior capsule and IOL get stuck and there are less chances of rotation.
Okay.
And same way, at the end we have injected moxie with BSS. So this is all. Anything, madam, you want to comment?
No, I think we are seeing a lot of new things here, and that is the best part. That a lot of new things a lot of innovative things are being shown. All innovations done by you, and again showcasing all these innovations. I think it is really good. Otherwise, we don't get to see them, all in one place and all in a one Surginar.
Oh, thank you, madam. So we proceed for the third case. You can start the third case. What's the time? Time ke service? 4:30. 4:1. So we finish this and we'll show the.
Yeah, we have the third patient.
Yeah. So by the time the third patient is come, I will show you one beautiful technique of a CCC in a hypermature white cataract. So first I will show that, and then we'll go for third case.
Yes.
हाँ? सिंपल ही करना है, सिंपल ही करेंगे हम, सिंपल ही करना है. No, it's not to, because we don't have time now. So just close it. Close it. Time for the third case, which is showing how to prevent the agitated flexion, but I will show the 3-minute video by the time the
Okay,
patient is
okay,
prepared.
okay.
So this happens once in a while when we go for a hypertrophic white cataract, we make a small cut and it can go in a periphery. Even whatever we give a mannitol, we give a glycerol, we make the speculum loose, we give a block, we give a pressure after the block, super pinky and whatnot. But you've seen that very clear cut agitated flex sign, which is named by one eye surgeon of Argentinian, who is just looking like a flag of Argentina. So after luckily I could do the surgery and finished it. But all the time you are not so lucky to finish the surgery in all Argentinian flex signs. Patient license. So patient is getting prepared, so by that time I can show this. So I'm very much proud that I was the first person to introduce trypan blue in whole Asia. We had done this study in '94, and you can see this is a way you can make the puncture. If you make a puncture in posterior capsule during phaco, why not in an anterior chamber? So this puncture makes three things. It makes the puncture on anterior capsule. When it is getting aspirated, so it aspirates all the fluid, which is a interlenticular fluid, which is responsible to give a more pressure, which is under pressure, and it is controlled very well. So the advantage of this technique compared to other technique is that we can have all the things at a time. No sooner the puncture is made, we suck out the fluid instantly. Diameter is 150, phaco is hardly 10 or so, and you just wait and suck out the fluid with the same instrument, phaco probe, and with the forceps we can make. So you can see that the rhexis is coming on the central part. There is centripetal force. So this very beautifully suggests that the whole the nucleus is collapsed, the capsule is collapsed. That's the sign. So you can see no sooner is punctured, the fluid has come out, and I kept one case as a live for this if time permits. So this is how you can prevent the agitated flex signs almost in 100 cases, 100% cases. It is done very well. And the irrigation, which is at the mortal height, which is passing over the anterior capsule, gives a positive force over the capsule, so it also helps in suction by the phaco tip. So outer pressure and inner suction. So this is how the fluid is taken out. And if you like, you can do it again. You can suck after initial puncture also. Give a viscoelastic and finish the rhexis. Now we proceed for the next case. It is, I just scrub and come back.
Sir, have you ever noted any extension of this into periphery while doing this kind of a puncture like this?
Yeah. We can, at least in this technique, I have not seen that it has gone in periphery.
Okay.
Because, in intramuscular white cataract, the whole cataract is full of a fluid, and this fluid is giving a pressure from in to out. So no sooner we make a puncture, the cut is like a balloon, And what we do is, we don't allow time to capsule to get it, get it extended. So puncture and suctions are done together. Say, just a minute. So by this, and second thing is there is a pressure of a fluid of a irrigation that is equivalent to the pressure of the bottle height over the entire capsule. So externally there is a pressure over the capsule and internally there is a suction, and beautifully this is all are done at a time simultaneously. So you don't give a time capsule to go periphery. So that's why it is almost 100% you can get this result.
Is it your preferred technique in all the cases of swollen lens and hypermature?
100%, sir. 100%. As a routine, even my all juniors are doing this thing.
Okay.
And it is, we go to third case. Yeah. So now proceeding for the patient is ready now. For the third case, which is a case of a patient who is a male, and we are going to put a techniques IHANS. IHANS, I know financial interest, but IHANS is a choice of IOL in my practice. We have implanted more than nearly 1200 plus IOL, techniques IHANS, and we are very happy with it, results. The patient has a grade 2 to 3, diabetes under control, and reports are normal. Next. This is its, we can say the IOL master. Next. OCT is normal. We take OCT to and all patients. Can go the further first topography. Yes. Okay. Next. I think there is some differences. Yes. Yes. This one. So you can see the astigmatism is more or less regular. There's not a much difference in, but you can see the little bit more on the lower part. Next. In this case, we are going to put a incision. I think this is a different patient. This is not a toric. There is some mix up of the two sheets.
I think this was a previous patient we saw.
I think there's a previous actually. Okay, so you can show here. You can show this. So I show you in my workup printout. So that's why case papers are not detailed. Once you have this workup, we mentioned which OT will be there, where the positions of the surgeon. You can see that we are going to demonstrate here OCCI, that is opposite clear cornea incisions, and there is very complex. We can say a software, whether we are going to put the incision vertical or oblique or same OCCI, yeah. So or temporal. So according to that, the software will tell you are going to put a rectangular incision of a corneal tunnel or a square, and what is the size. And here we have calculated that 2.8 opposite is 2.8, 2.4. So in this case, suppose the patient, we can go for a one diameter of a toric, but the patient is not willing for a toric, so we have chosen this case. Here again you can see the endothelial count is 2769, that is normal. And there are few things we mentioned also, that whether patient is a first one anti-VEGF to be given, whether patient is going to be under block, or patient we are going to keep a blue dye ready or not, patient has been cold previous day, charges are final, and so on. And we write down all the medicines in this printout paper, what is the batch number, what is the expiry of each and every medicines. And right side you can see the investigations are normal, and it is also to be checked at the last moment, including SpO2. So once this printout is there, then patient comes inside the OT. Thank you. So we proceed for a surgery. Must keep her.
I think it is a complete app that way. I mean, it just directs you and tells you also what to do. Inject Viscoat or inject, Orocoat, and then OCCI, everything. it just dictates you to do.
Here patient has a astigmatism of, as I told, the 0.88, and that astigmatism patient is, we can go for a 1 diopter of a IOL, toric IOL, but this is a demonstration, like what we should do, the patient for a થોડીક ઓછી કર ત્યાં રાઈટ સાઈડ થોડીક ડાઉન નહીં નહીં લાઇટ યસ ઓકે ઓકે no light bus, that's all. So we can mark this patient, but to save the time we have not marked this, but I'm going to put a incision at 20 degree, which is here, that's the main tunnel, and my right hand, which is again in a circle, I'm sitting on a 20 degree, my table is at 20 degree. Right પર જઈ આંખ હલાવતા નહીં હા. Yes.
So again, I think that is a very elegant way of making both the incisions. I think we should also start doing it, Rajesh.
Yeah, completely agree with this method of making the two side ports. It's a wonderful way of doing. So you don't have to hold the conjunctiva, you don't have to do anything. I mean, there can be other ways, but this is a wonderful method of doing it.
A bolus of orocort, and then below that bolus, I put a little bit viscoelastic. So again there is some bubble is there. Better to suck it out for demonstration purpose. Visco. Sorry, is it on? I don't want a soft ice. I'm injecting again. You will notice that I'm not making a main incision now. Very helpful in a hypermetropic patients who has a very shallow light. You can see the very well clearly.
Yeah, we can see very clearly.
Says visual on much. You know, juniors go on asking me that what way we have to do the raxes, clockwise or anti-clockwise. The answer is very simple. If you make a circle, when you are doing any drawing or any circle clockwise, then do clockwise. If you are making the circle anywhere anti-clockwise, so it's a basic control of our hand, we have to use it. So both ways are good, but if you have a habit in clockwise, you can do that. So here there is a roughly, so I'll show you that this is a 2.8 millimeter incision, which is a very good incision so far as fluidics are concerned, and so far as the nullifying the pre-existing astigmatism, and at 20 degree. Second one? Okay, good. So we do the gentle hydro, trying to do in such a way that the fragment of entire capsule comes out. If it is okay, otherwise we can remove by, you see it has come out. Dr. Darjisi had taught me that use 1 cc or maximum 2 cc of a syringe when you do the hydro, so that you have better control and better flow.
So what cc syringe do you use to do hydro?
This is 2 cc, 3
Okay.
cc. Yeah, this is a 3 cc, it is 3 ml. And yes, and never use any syringe for hydro. This is locked so that it doesn't come out or shoot like a bullet. Otherwise, so always use the syringe which is a lock, lever lock, what we can say. If needed, the sister will put additional 1 or 2 drop of paracan. You see, the two-hand technique for the rotation is very good. There is only a rotation force over the nucleus. There is no stretching of zonules. And as I told you, I do little bit on the reverse side so that the epinucleus is detached from the
This is a
cortex.
kind of wonderful technique. Very nice.
Thank you, sir. In previous case, I was able to see the golden ring. So what I did with the help of a tool chopper, I cracked the nucleus with chopper only. Because the patient is a less endothelial count and we can save this some phaco power. But it can be attempted only when the iris is coming out a little bit. थोड़ा height aussi करो थोड़ा. Trying to separate it out. So, the fragments must be separated completely from the mother's brother fragment. Otherwise, there are lots of issues like flower pattern, and you cannot. So I'm just confirming it that it is separated in the center. You can see now. So it's not a very hard cataract. So either we can crack it further like this and absorb one by one. I think it needs a viscoelastic. Patient is light material.
Light one? Yeah, okay, okay.
Yes, put a little bit viscor over the surface of iris.
This is under topical or this is under
Yeah, all under topical. All
topical. So I think the patient is exerting some amount of pressure, so that is why.
Maybe, and I think for safety purpose, I'm making it a little bit more dilated for safety and demonstration purpose, so that it does not constrict further. It has started constricting. You can see a little bit more dilated than what it was. Vacuum करो.
25.
Height 90 करो.
90.
Okay. So this is again under Venturi pump. The beauty of dual pump is you can do any vacuum of your choice. Just catch with the vacuum, don't do phaco here. Make it come to the very comfortable central zone of a safety. So here I am using very less phaco power. And you can see my tip is always blocked all the time. It is never free.
Yeah.
It is the beauty of a Venturi that you remove more material and less fluid. peristaltic, you remove more fluid, less material. Because there is some fluid is in and out and creating a vacuum in peristaltic. Just touch and suck and then you can do it. I think off कर दे. So this is again the same thing. Why I'm putting the second time is I'm confirming that the eyeball is very tight. So I want a stretched and expanded capsule. So once the whole capsular bag is under pressure and stretched, then the stripping of removal of the cortex is very easy. So same thing we do, and I teach my juniors: catch, pull, and then aspirate. 100 crore. Highest crore. So if you are not comfortable, you can change the hands. Not necessarily you should do with, you can exchange the hands, and you can exchange the irrigation aspiration. So irrigation is on, and once I fill it with the viscoelastic, then I off. So again I'll put extra visual on because I want the capsule back stretch when I implant a IOL. So again I'll tell you that I know finance interest, but ICB00, that is iHans, is a beautiful lens which has a unique property of extended depth of focus IOL, and of course it is a excellent material, and it has a little bit add-on power. Exactly I don't know how much, which is not revealed by the company, but some addition of a power is there in an anterior surface of IOL, which is very gradual from periphery to center, very smooth transition of a power, giving rise to 1.25 diopter of depth of focus. So at least in my patient, when I keep the target minus 0.3 or so, patient can read at 50 centimeters of distance. That is a computer or reading on notice board or something like that. You see, I always have a counter control with the left hand, and why I used a dialer in left hand? Because if I want to dial, I don't have to ask for dialer to the sister to reposition the IOL. So to have a control and counter pressure or the eyeball, because patient is under topical anesthesia, so you can put this inside. So I don't touch any instrument. With the help of Visilon only. So you could see that here we could use the Visilon as a instrument. So now we are going for a OCCI. So this was a 2.8 incision, and as per the software says, you should put exactly opposite, that is 2.4 incision at 20 degree. So here again, we have done lots of study on this, and we developed the one, we can say the nomogram and it works. Dr. Sato, who was in Japan, Dr. Sato taught RK to Dr. Fedro. He was saying rather, that it is an internal incision which makes the cornea flatter, not the external. So I don't do a AK, that is arcuate keratotomy or so. I do only through and through complete incision. So you put that it is combination of the two things, 2.4 and 2.8, giving rise to nullification of a pre-existing astigmatism of 0.88. Now you can see that I put the lens oblique,
Yes.
that is nasal
Yeah.
up and temporal down. So there was some study in ASCRS that this gives a minimum chances of negative and positive dysphotopsia.
Okay.
So if restriction of toricity is not there,
Yeah.
if you have freedom to put the lens in any direction, I put it like this, especially this design. So don't forget to hydro the opposite OCCI, because that is also equally important. Now coming to the last step, that is we must remove whatever viscoelastic residue inside the eye, and also viscoelastic behind the IOL. So this 30-second helps in very well in preventing the post-operative high IOP spike. Once we remove this, the chances of blockage by viscoelastic to the trabecular meshes are very less, because you removed almost all. Again, lift up make the speculum loose, lift up both the lids with the other hand, and then inject the irrigation, so that your eyeball is maximally, we can say, filled with the BSS. You can see here, I take a support of upper lid or towel to inject the moxie. So my hand is more stable. I think some air is there, it's all right. So this is the end of the surgery. I should thank my patient
nice.
also.
But no, I think
Very nice demonstration, and you described each and every step very nicely, sir.
Oh, thank you, thank you, sir.
Clearly, and I mean the concept was absolutely clear, and it was a very good teaching kind of a video, sir.
Yeah, thank you very much, sir.
I think so many innovations and so many tips and tricks even we learned. I mean, things that we were really not aware of, and things which look so convincing, especially your white cataract management with the trypan glue. And I think you would be the first one to describe, and then possibly Panchorex's, was taken up from this, because this was described much earlier than that. So I think so many things actually we also learned today. So many.
The beauty of ions is it really gives very good result, and in housewives and other patients, what I do is I target little bit 0.6, not more than 0.6 or maximum 0.65 to the other eye. So one eye emmetropic, another eye little bit for the near. So one eye patient can see the 50 centimeters, other eye not 33, but it will be in between the 33 and 50. So patient can be more or less free of glasses if we do the micro monovision like this. So that's another advantage.
Yeah, and I guess this patient was a diabetic one, and in diabetics, one can, there are pluses and minuses in terms of thinking about use of multifocal lenses. So
Yes,
you can very safely and without any hesitation, you can put Eyhance lens, because it is a monofocal lens with some degree of defocus curve, providing intermediate vision. And as you said, sir, that in some patients you do keep the target refraction at minus 0.6, 6.65. So that really is very useful, and the patient can be sort of spectacle independent, become spectacle independent in such a
And
situation.
second thing, the toric 2 lens has we can see the frosted edges. So rotation, the IOL itself does not rotate much. So there is another advantage because it is not smooth, it is a frosted. And of course, we all know that the aspheric platform is also very good. When a combination of asphericity and also add-on, which helps a lot in a overall outcome. I think it is 4:30. So we can I think we will skip the last case because the time is over. Whatever I wanted to show is I showed in a film that how to puncture the, and if the time is there I can show the rexis part.
Yes, sir, you can see the rexis part.
Okay, okay. Oh. And this is once we do the calculation under optical biometry, especially it has a, but it's all right, just all right. Especially when we do the toric K, so it is observed that anterior K and total K, or in other words, in Barrett's words, printed PCA and measured PCA. If we compare the two results, when we do the measured PCA, the correction and the chances of target emetopia is more in a photocalorimetry, and you may go wrong in measured PCA by 13% of the cases. So in measured PCA also there is some calculation. So the temporal will add half hour more, vertical will add half hour less. So there are so many calculations which is estimated posterior corneal curve, corneal estimatism. So, but my experience is that when we measure the total calorimetry, it helps a lot. So we'll proceed for the last case. I think we'll show the CCC,
Yes.
and then we'll.
Yes, I think it was really lovely seeing all the cases, and you have been into this phacoemulsification for the last so many years, and also have been at the helm of all the societies, whether they are international, national, well attended, and have innovated your own techniques, your own tips and tricks, your own app. I think today's demonstration was just we were privy into all those things that have been done over the past so many years. I think it was a very useful and educational, you can say, a surginar or surgical class that we had today.
Yeah. Thank you. Microsoft. आप बताओ ना, तेरे बताओ ना। हाँ तो आप बताओ, ये शो दिस वांडो ने हाँ टेम्पर आप बताओ ये शो दिस हाँ नहीं हाँ ठीक है. Yes. So this is a whole. So the red is for right eye, and the teal color is for the left eye. So this is how it is designed, and it is stuck on the. Can it make a full screen? Sage amber, yes. In a white cataract, usually, you know, if the estimation is not much, I prefer to do the surgery at 180 or temporal incision. क्या मतलब एक्सिस बंद नहीं हो सर कैप्सुल एक्सिस फॉर्सर so you see and patient is also under topical anesthesia my call sir yes sorry ocular sir good hey, anesthetize a little bit. First thing I will do is a staining and I produced trypan blue a water costing only 30 rupees. It made 1000 ampoules and given to different surgeons of India to evaluate. And once it was in, first it was marketed by one company, it was costing $100. So, once you done stain, you observe that I injected the air again, because here is very important, we should not stain the endothelium. So now I am trying to wash it out. So how to wash it out is in and out of the fluid, in from the right side and out from the left side. So this is how I will remove the excess of trypan blue. We must also know that trypan blue releases, reduces its elasticity of a capsule by 27%. In a white cataract, I want to put a little bit pressure so that entry. Centering करो. Okay, centering करो.
Centering the front.
Yes. Zero. I remove the air bubble for better demonstration. Light માં જોઈ રાખજો હા So this is FECO 1 with a 150 vacuum and power is very minimal. If you want, I will magnify the center part. So just introduce it inside, make a small dent or some pressure, little bit touch it. You can see the touch.
Yes.
And once it is touched, make a puncture. And once it is punctured, suck it out, the fluid.
Okay.
Okay.
Yeah.
And now don't use any other thing other than heavy viscoelastic. You need a heavy viscoelastic because it is easily going to go in a periphery, and as here there is a increase intra-lenticular pressure, it is better to use forceps and not for the main port but for the side port. The reason is side port can collapse the antechamber, and the forces over the capsule will be centrifugal. Here we want a centripetal force so that we have better control over the. So this is how you can do each and every patient in Forcible.
Nice demonstration, sir.
Yes, thank you, sir. So rest you know very well. So my junior will finish the case. We can discuss. One more thing is I would like to narrate here is these lenses are natural. So required because a lot of fluid. Again, you can make a rotation a little bit on the reverse side, and that's all. No, take on.
The very nice demonstration of the Rexes. Excellent. It looked absolutely effortless. And you also showed the spiraling of the Rexes, I think, which is required in these cases.
So, I think my junior will take over the
Appears to be a hard cataract.
Yeah, it's quite hard. 90. Chances of corneal burn are very less in this machine because I have 2-3 other brand of machines. I don't want to criticize any company, but corneal burn is a rarity in this type of a hard cataract. Two.
25 hour. This 25 IQ.
You can see I'm going to level 3, very, very deep. Then you can crack it. So one here, second here, and third here. So there are 3 actions for chopping the hard cataract. So you can confirm that it is now separate completely. Still I have some doubt in a center. So making it rotation, fixing this highest height. You can see, go as deep as you can see and separate it completely. Don't proceed until you are happy with the crack. You can stop it now. So my junior will take over the case because I have cracked it. I think. Thank you.
I think.
So, I thank you for giving me some few more minutes.
No,
I
no,
want
no.
to show this
Nice demonstration,
because
sir.
this is my very favorite technique.
Yes, yes. Even we wanted to see it because the videos were so good. So really excellent demonstration of cases today, Dr. Rajesh. What would you say?
Absolutely, absolutely. That's what I was telling earlier also, that every step that you showed, you explained very well that why it is being done and how it should be done, what is the advantage. I mean, this was a complete teaching video, kind of a teaching Surginar, wherein a lot of points have been taken up by even the best of surgeons. They can incorporate your technique into their own technique. So I must say that for me it was a very good learning experience and very nice. Thanks a lot, sir, for demonstrating every single step very nicely.
So I thank all of you, and I thank my staff, my anesthetists, my OT sisters, and also AIOC who has given me all the chance, ARS for this, and thanks Dr. Nambita, Dr. Rajesh, and I also thank to J&J for giving me this opportunity to show a little bit what I know to my juniors and to it's my first experience of a Surginar online. So I'm very happy and thank you.
We would also
Any
like to
questions?
thank
So you
J&J for showing us such nice Surginar, and it was a wonderful experience.
So thank you so much, sir. We hope to have you again on another Surginar. It was, if I may say so, the most educational Surginar we've had till date, although we've done so many. But I think so many tips and tricks we've never learned in a single Surginar. And it's a encyclopedia of the tips and tricks itself. So thank you, and I'm sure we're going to have you again on our platform and learn many more things which we would have missed out today. We would like to thank Johnson and Johnson for sponsoring this, like always. Your entire staff, sir, and your patients who would have taken out time, especially to do this. And we would also like to thank our office team, the headquarter team, as well as the audiovisual team, led by Mr. Gaurav, who did a wonderful relay of the live surgeries. Everything was very clearly seen and very nicely focused.
Thank you, madam. Thank you, sir.
Thank you, sir. Thank you.
Thank you. Looking
Thank
forward
you.
again. Thank you. Bye bye.
Yes, sir.
Bye bye.